Hi, I'm Dr. Molly James. I'm board certified in general surgery and critical care. And in these confusing and crazy times, I thought a lot of doctors who don't manage ventilators every day might be called to serve on the front lines and manage a ventilator. So I wanted to go over basic evaluation of hypoxemic respiratory failure and just hit some high points. So at the end of this video, you should be able to interpret an ABG, delineate severity of hypoxemic respiratory failure, identify ARDS, and we'll talk about salvage strategies. So there's a couple of things we need to define first. The first one is PaO2. If we do a blood gas and we check the pressure of arterial oxygen, that's what that value is, and that comes from the blood gas. FiO2 is the fraction of inspired oxygen, and that's how much oxygen we're actually breathing in. So if you remember, when we breathe room air, the percentage of oxygen is actually 21%. So as I teach this, I'm going to round that to 20% just for the math. So if you remember, so if we start with, I like to start with things you know, so then you can build the things around that. So if you start with we breathe in 20% oxygen, when we do a blood gas on a healthy patient with healthy lungs, we expect the PaO2 to be somewhere around 100. Now that can actually be anywhere from 90 to 120 or so, but roughly 100, and that makes the math pretty easy as well. Okay, so that's room air. So then what we need to figure out when we do a blood gas or evaluate someone for how hypoxemic they are, there's a catch, because when you do a blood gas, sometimes the PaO2 can show up high even though the patient's in hypoxemic respiratory failure. And where does that come from? So when we look at the expected PaO2 versus the PaO2 that we get, that is called the AA gradient. So we need to first know what the expected PaO2 is for each FiO2 or each level of oxygen that we give a healthy patient. So again, if I double it from 20 to 40%, I would expect my PaO2 to go up to 200. If I go to 60%, I would expect that to be around 300. 80% would be about 400. And then 100%, we would expect that to be 500 to 550. Another way you can reconcile that is if you know atmospheric pressure at sea level is 776 millimeters mercury. And then we've got dead space and we've got diffusion losses. So if you take off a couple hundred, if you're breathing pure air at atmospheric pressure, you're going to end up with a PaO2 of around 500. Okay. In practicality, we see this. Patients who come into the ER with isolated head injuries and we do blood gases on 100%, we usually are going to see their FiO2 or their PaO2 be fairly high. And then we're going to know how much we can titrate the oxygen and how quickly. So if you have a patient come in with respiratory failure, let's say we intubate them, and then we get a blood gas. Say we put them on 60% to start out with. No, let's say we put them on 100%, because that's usually what I like to do. Get them intubated, put them on 100%, and see where we're at. That's where I like to start, okay? So if you get a blood gas, and say their PaO2 is 300, so on your blood gas, that's going to read as if the oxygen level is high, because it's out of that range of 90 to 120, which is normal for room air. Their oxygen level isn't high, though, because it should be 500. So this differential here is your AA gradient. That tells you how sick they are, okay? So again, you can figure out for any level of oxygen that they're on, what should their PaO2 be and what is it actually, okay? And that gives you an indication of how sick they are. So now where does ARDS fall into this? So if you have a patient on 100% oxygen, we're going to talk about something about a P to F ratio. So basically what that means is the PaO2, so this number, to the FiO2, if it's less than 200, that's ARDS. And again, if you're using 100% oxygen, the bottom number is 1. So on 100% oxygen, if your PaO2 is less than 200, let's see, I put 200 here. So this is ARDS zone. Okay? So if you're in this zone with your patient, you need to be on the low tidal volume ventilation protocol, and I'll go through that on a different video. If your PaO2 is less than 100, you're in severe ARDS. And you need to be looking at salvage strategies or appropriateness of ECMO and things like that, what's available at your facility. Okay? The other thing that we haven't talked about, so your PaO2 is going to come from your arterial blood gas. Your FiO2 is going to come from your ventilator. We haven't talked about oxygen saturations at all. And that is because for a PaO2, so I'm going to put, for a PaO2 of 90 or above, your sats are 100%. And if your PaO2, let's see, I'll do 50 here, is 60 or below, your sats are less than 90%. And in this range, it's 90 to 100%. So you can get fairly easily lulled into the patient. If you're using PaO2 and you're at a higher inspired oxygen, it's really not going to tell you much because your patient should be above this line anywhere that they may be. But again, if they are desaturating wherever they are, you know, the further left your bars are, you can jump up. And then once you get all the way here, you can't jump from your 100%. So then we talk about salvage strategies. Okay? That should clear up how to interpret the oxygen on a blood gas. Tune in for the next video on vent modes and then ARDS management.